to start the timing here so I can keep track of where I am in my slide deck. Thank you, Brian, so much for the kind words. And really, this is an opportunity for me to, I have no disclosures. Really, this is an opportunity to highlight the ongoing work of myself and my colleagues under the guise of discussing cell-free DNA and the prenatal screening and somatic arenas. Some of the testing we're going to talk about today very much is standard of care, and others are not yet quite ready for prime time. Please note that there is disagreements amongst leaders in the field as to some of the classifications I'm going to be offering here, but it's part of that discussion that we can have at the end about where I think it's useful and where it may be we haven't got enough information yet. I'm convinced our residents come to service thinking that this is, how I visualize the world, but really our molecular data looks a little more like this. So if you haven't spent time with me on our service yet, this is our IGV software. And what we're looking at here is actually a mutation in BRAF. I tell the residents all the time, if you don't know what mutation, if I ask you what causes a cancer, just say BRAF V600E. We'll discuss why here in a minute, but that's what we're looking at. You can see the reference at the bottom. There's a to T change at the valine position. And so, like I said, V600E, right? Look for this to pop up a few times. The presentation is going to be in 3 parts. A discussion of cfDNA as an analyte, so a little bit of background information, and then its utility both in the prenatal setting and the somatic setting. This timeline highlights advances in cell-free DNA against important benchmarks in the molecular revolution. It was first identified in 1948 by Mandel and Matthias, and it would take about 30 years for them to understand that this was actually an analyte that was increased in cancer, and another decade after that before they understood the increase was actually from cancer. It wasn't until the early 90s, however, that Sorensen et al. Actually demonstrated that the KRAS mutations that they were detecting in cell-free DNA and circulating tumor DNA in the blood were identical to the ones that they were seeing in pancreatic cancers, right? It was this work in cancer that prompted Dennis Lowe to hypothesize that you could actually see bits of fetal DNA in mom's circulation. And a short 15 years later, non-invasive prenatal testing was born, made commercially available. 5 years after that, the FDA approved the first cell-free DNA test for lung cancer for looking for EGFR mutations. Now, I've mentioned cell-free DNA a lot, as if it was just a single analyte, and usually when we think about it, it is short fragments of DNA. But there's also long fragments. There's mitochondrial DNA. There's DNA that's being ejected from erythroblasts. There's even RNA present in circulation. But we also have the DNA that's associated with proteins and in membranes and apoptotic bodies. And so all of this can be present. All of these bits of nucleic acid are byproducts from a number of different processes, most prominently apoptosis, but necrosis and other mechanisms also figure in for different subtypes. Don't worry, there's no quiz on this part. It's not one of my post questions. And they're due to a number of normal physiologic processes, but also several underlying pathologic diseases. As I've alluded to, we're going to focus on the pregnancy and neoplasia aspects, but it's worth noting that transplanted organs, autoimmune disease, infection, and even trauma can contribute to the cell-free DNA compartment. The underlying process, why this is being put out into circulation, can affect the size of the cell-free DNA fragments. Normal cell-free DNA is about 166 base pairs, the size of the nucleosome plus linker. But when you're looking at fetal, or really placental DNA, circulating DNA, or you're looking at tumor DNA, the size is shorter. It's about 144 base pairs. And they think this is due to changes in the access of DNA to enzymes that are present. As it turns out, and we won't discuss this too in depth, but we actually think the way that we're isolating these fragments have skewed our understanding a bit as to what their actual size is. Truthfully, I've actually oversimplified the size. There's a number of different factors that contribute both to the size of the cell-free DNA, the amount that you can detect, and the half-life. Location is one of them. If we're looking at cell-free DNA from the saliva or the sputum or the urine, these are very short fragments. But if you're looking at something from seminal fluid, these can actually be over 1,000 base pairs. When we're thinking of cell-free DNA from a fetus or placenta or tumor, we also have to think also about what normal DNA might be diluting that diseased DNA that we're looking for. This can be free-floating DNA, or it can also be DNA that's present within cells, like white blood cells or mesothelial cells, depending on what compartment you're in. And we have to think about microbes if they're present. There's a number of filtration and degradation considerations. There are, if it's bound to protein or within membranes, it might linger a little bit longer. There's size exclusion. It doesn't pass the blood-brain barrier. Only small fragments pass into the urine through glomerular filtration. We have to think about clearance, its uptake in the liver and spleen and lymph nodes, and whether there's enzymes, digestive or otherwise, that are digesting it. Neoplasia, whole other set of variables. The type of tumor that's present can affect the size and the fragmentation, where this tumor, so where the fluid you're getting, and how that tumor is communicating with that fluid can affect it. Your disease burden and stage. If you have a higher disease burden or a higher stage, your fragments actually seem to change a bit in size, which is really unusual, right? The proliferative index, and also whether there's necrosis. All of this is changing that compartment. There's extrinsic factors to consider as well. Where are you in your therapy? Has there been radiation or chemotherapy that might be changing how much DNA is present? Are there inhibitors in the food or beverages that you've been drinking? Even brushing your teeth can change the amount of cell-free DNA in your saliva. All of these different compartments can be accessed and can be spun down. You do centrifugation, you just card the pellet, and you're going after the material that's present in that supernatant. And from there, you can put it on a number of different testing modalities, just depending on what you're looking for. So we can see things like single nucleotide variants. This is probably where you think we spend most of our time, right? BRAF V600E. There's copy number changes and fusions to be found. But there's other things you can look at as well. The fragmentation patterns, the size, the epigenetic alterations, if there's methylation present, how that's changing the nucleosome footprint. What is the topology? Is it a double strand or a single strand, linear or circular? Obviously, this is what I like to focus on. And we have a lot of different methods for assessing these alterations. I'm going to focus on the next generation sequencing, but some of these others will come back up at the end. I like to tell our residents next generation sequencing isn't one assay. It's not a one size fits all. There are so many variables that can be present between different assays offered by different companies and academic centers. We're going to highlight a few of these in the next slides, but really material selection can be key. Nucleic acid extraction, so are you going after DNA, RNA, sizing of that, target coverage, and then the platform, right? The way that we're finding these mutations, and the skill set of your bioinformatics team in their black box, so to speak. And really also the skill set of the variants, of the molecular staff interpreting these variants. I want to use an ice cream analogy here for your target coverage. When we think about hotspots, or you think about just looking at very specific mutations, this is really just a tiny, tiny amount of the base pairs that are present in the human genome. And I can't tell you the number of times that I've actually stopped arguing with our clinicians who say, I don't need BRAF or I don't need EGFR, and this was already done elsewhere. And we go ahead and run it on our panel for whatever the genes are they do want. And then when I find an EGFR or I find a BRAF mutation, I email them. And the question is always, well, how did this outside place not report that? And it all depends on the coverage. If you're only covering specific codons or specific exons that contain those mutations, you're not going to see everything around it. BRAF is my favorite gene. I don't know if everybody else has a favorite gene, but this is the one I spend a lot of time thinking about. And I can say 600 and 601 are super common, but I could rattle off a whole other list of numbers that other places aren't necessarily looking at. Whole exome sequencing, instead of an ice cream scoop, now we have the decked out ice cream cone, right? 20,000 genes that we're looking at. And if we continue with this analogy, then whole genome sequencing would be that ice cream sundae. I'll tell you our oncoplex falls somewhere between the ice cream scoop and the decked out ice cream cone, and pDNAs, our prenatal screen, would be more over on the ice cream sundae end of the spectrum. Okay. Neoplastic content is another thing that we think about a lot. And you're looking at copy plots here. Each chromosome has its own color oriented from, what is that, left to right, chromosomes 1 through X. And if you're at this 0 line that may be a little bit hard to see, then that would indicate that you have no copy changes. Above that, gain. Below that, loss, right? And if I compare 60% to 10% tumor, I think it's really easy to tell that even knowing exactly where to look for copy changes at 10% tumor, I could potentially miss them, right? Like I can't see the vast majority of those copy changes. The same is true of point mutations. Our assay requires that we have about 5 to 10% tumor. Same would be true for cell-free DNA. If you don't have enough of that analyte present, you can't make the call for a mutation. So here we have BRAF V600E and a melanoma. I'm able to tell the clinician that their patient is positive. They can get a drug. And here we might miss it because it's only a couple of reads and it's under the limit of detection of our assay. We change the depth of coverage depending on what we're trying to do. In our low-pass whole genome sequencing, on average, less than 1 base pair coverage, or 1x coverage per base pair, I should say. And this is great for copy number alterations, but you aren't going to detect point mutations that way. If instead you use something like Oncoplex, where our coverage is on the order of 300 to 2000x, then you would actually be able to tell or detect point mutations in addition to those copy alterations. I've mentioned LOD, limit of detection. All of this kind of fits together. When I did my PhD, I did Sanger sequencing. And that basically meant that I was looking at all these little traces up here. I know the residents are laughing. Clearly that was a while ago. And I would argue with my PI about whether or not these little bumps that I would find in the sequence were real. And the only way to get at it was to clone it into plasmids and then culture these out and sequence a bunch of plasmids to prove that you had this subclonal mutation. By the way, I was right. But next generation sequencing really revolutionized that. You didn't need 25 to 50% tumor. We could now look at 2 to 5% tumor, right? Or 5 to 10% tumor, I should say, 2 to 5% allele fractions. And then droplet digital methods really took this to a whole nother level, and you can find variants present at 0.001%. I mean, how phenomenal is that? You can take someone's blood and look for an EGFR resistance mutation. And those were the kinds of assays I read out when I was a trainee. Now, next generation sequencing can approach that limit of detection in digital PCR methods. And the way that they can do this is using unique molecular identifiers, UMIDs. Some might have heard this as barcodes. So this is basically where, in addition to the barcode that's telling you we have X patient, we also have barcodes that are unique to each fragment of DNA. So what you're able to do is see if a mutation is present in all of the same fragments, collapse those reads to be able to tell that that mutation is real and not a sequencing error like what's being shown in the circles. And so this enables you to approach that 0.01 or 0.001%, depending on the sensitivity and the depth to which you're sequencing. And it generates thousands and tens of thousands of variants when you're doing all of this, and you've got to figure out how to sift that haystack and find the proverbial needle. And that's really where our wonderful bioinformatics team has just, a joy to work with and made it possible. Rarely has an assay been embraced as readily as cell-free DNA in pregnancy. This really revolutionized what we were doing with pregnant women in terms of screening tests. It's estimated that in this last year, insurers will have spent about $7 billion on these non-invasive prenatal screening tests. Thinking about what accounts for this growth, I think if we compare what we see on the quad screen, right? So where you're looking at proteins in mom's blood, or integrated screen where you're looking at those proteins plus imaging, you can see orders of magnitude difference in false positive rates and also profound improvement of sensitivity in cell-free DNA compared to those other methods, especially when we think about the women that were being screened for proteins and for integrated screening. This was that high-risk population, and cell-free DNA really was offered to everyone that wanted it. And so that really is just a phenomenal improvement on standard of care and why it was so readily adopted. Of course, we weren't content to stop at 13, 18, 21 in the sex chromosomes. It rapidly expanded to all of the chromosomes to detect aneuploidies outside of these classic trisomies. As it so happens, we do have an assay here that can detect these alterations. This was brought on before my time by Dr. Tina Lockwood, who I'm fortunate to call a friend and mentor. The way that this works is to take a peripheral blood tube from a pregnant woman at 10 weeks gestation, and they isolate placental DNA, right, as well as the maternal cell-free DNA that's present within the plasma compartment. And this is subjected to low-pass whole genome sequencing aligned to a reference, and then allele counts are done, or counting statistics, right? So you're looking for your normal number of chromosomes. If there's a gain, this would be a trisomy, and a loss would be a monosomy. And the way that we look at this, each one of these is a copy plot, very similar to what I showed you with the Oncoplex copy plot, and oriented from proximal to distal on the chromosome, and each one of these is a 1 megabase bin, and they're overlapping. And you're looking for these to all cluster around the 0 line here in the center. So this would be an example of a normal chromosome 13, and a normal 18, and a normal 21. Seems relatively straightforward. Everything's around the 0 line. And I can take all of those little blue dots, and I can average them to get one signal per chromosome. So we have chromosome 1 here, and 22 over here. And so this would be a normal screen. Everything's great. Baby is healthy. Just a reminder, here's a normal screen on a euploid male fetus, 15% fetal fraction estimated by measuring amount of Y, and a normal chromosome 21. And if we compare that, you can see down here, similar fetal fraction, we've got gain of 21. And if we look at all of the chromosome 21, you can in fact see that all these little blue dots are above that 0 line. So this would be a place where we would say, we're concerned that there's trisomy 21, this is a screening test, you should have diagnostic testing to confirm. A different example, just a reminder, normal on the top. And here instead, we have gain on a different chromosome. This is 16. And again, if we look here, it's a little more subtle than the last one. The fetal fraction is lower, but all of the dots are above that 0 line. So there would be concern here for trisomy 16. Most of our prenatal tests are negative, as would be expected, right? About 90% are negative. The next level, or the next number to think about, are the indeterminates. We're about 8% there, which is within industry standard. And the last 2 to 3% are our abnormals. If we break this down, about 40% of them are due to those classic trisomies, gains of 13, 18, or 21. Another 25% are sex chromosome abnormalities. 20% are due to rare aneuploids, so this would be the non-13, 18, 21. And then the last are accounted for by subchromosomal copy number alterations and also maternal factors. We're going to put a pin in the maternal factors for now. Maybe some of you are familiar with lay press talking about these tests. Back in 2014, it was why trisomy screening this way was bad, and most recently in 2022, this article came out in the New York Times basically saying that women were being told that they had these abnormal pregnancies due to microduplications and deletions, and they weren't being counseled appropriately, essentially, is what was happening, right? There is a false positive risk here, in particular for things that are very rare in the population that you have to take into consideration. And it prompted a number of statements from professional societies and the FDA reminding providers and reminding patients that really when they get one of these tests, it isn't 100% certain that it is a screening test, and it does require counseling and appropriate diagnostic testing following. So what do I mean if I'm saying microduplications and deletions? A really good example is looking for DeGeorge syndrome, right? So I'm not looking for all of chromosome 22 to be gained or lost. I'm looking for a small band to be deleted. And it's other gains and losses like this that we'll discuss next. My former PI would have my head for this slide. There is too much text, too many numbers, but really I'm trying to make a point here, which is that the sensitivity and positive predictive value of these screens can vary wildly. And the same is true of the specificity and false positive rates. Really what you have to think about is how rare these are in the population, and that when you have a sensitivity of 75%, it may be a matter of just having missed 2 cases in your entire population of 100,000 women. It can be a bit dependent on the methods that you're doing. And then really it's also focusing on the fact that for small defined changes, we're great, but if you're talking about all the microduplications and deletions across the human genome, the sensitivity and specificity there are going to be less on average. And that's really what this study was breaking down by disorder. So here, 86% sensitivity, this doesn't look as great, but it's 1 missed case. 66%, this was 2 missed cases. And then over here, when they were looking at all the CNVs, they had 30 to 40 different cases, different CNVs they were looking at. And again, that false positive rate, can you imagine 0.5% having a false positive on a screening test? That is just not, that's like going back to the original days of quad screening, right? Like that's problematic. Of course, we're not content to stop here. They're going smaller. And there's actually a number of monogenic disorders, meaning they're actually looking for point mutations in mom's blood to decide if a fetus is affected or not. And this is done, it looks impressive, this list, right? But if you actually look at the genes that are causing this list, there's a lot of overlap. It's still impressive. And it's done in one of 2 ways. There's relative mutation dosage and there's relative haplotype dosage. And I'm going to try not to lose you because I think I read this paper 3 or 4 times. It was really one of those, like, let me make sure I understand all the nuance to this. We have data up here, helpfully annotated mom, and then these are potential fetal outcomes. You have to think about the context where you're looking for the variance. There's de novo, so neither parent has it, it's arising spontaneously. And this would be, and as what's seen down here, right? So the mutation's in the fetus, but isn't present in one of the parents. You think about these very similar to paternal autosomal dominant diseases. So basically, if you go and look at maternal circulation, which has both mom's cell-free DNA and cell-free DNA from that placenta, if you find the mutant, if you find the variant, that means the fetus is affected. If you don't find it, they're not. I think that's probably the easier one to wrap your brain around. When we think about a maternal autosomal dominant, though, then we have a problem because mom's cell-free DNA already contains this mutation. Now you have to actually look at the ratio, the allelic balance or imbalance between wild type and mutant. If it's 50%, if it's roughly the same, the fetus is affected. If there's more wild type than mutant, fetus is unaffected. It changes again for autosomal recessive mutations where the mutations are the same because now you have 3 potential outcomes. If you have more wild type, fetus is totally normal. Roughly equal amounts, the fetus would be a carrier, and more mutant than normal, then the fetus would actually be affected. And it changes again, right, if you have a compound heterozygote, and it becomes a combination of looking both for the paternal mutation and then doing dosage on mom. This works fairly well in certain instances with highly trained providers, I'll do it that way. And it doesn't work so well if you have large structural alterations or deletions, or you have genes that have a pseudogene or they have repetitive regions. That requires something else, right? Because you can't do these counts for something you can't count well. And so there's another method used called relative haplotype dosage. And instead of looking for the mutation, you're looking for the thousands of polymorphisms surrounding that mutation to detect those presence and increase your ability to then identify that mutation. I don't want to go through this exhaustively, but the thing I want to point out here is that you get when you take from mom or you take from dad, all the polymorphisms, you don't know which ones are associated with that mutation, so the only way to make this test work is to have an informative sibling. So somebody else already had to be normal or abnormal for you to know which chromosomes were aligned with those mutations. Or polymorphisms, I should say. Okay. So I put a pin in something earlier, and that was, this was another case that we had on our prenatal assay. And if I was lecturing in the med school right now, I would actually use the Socratic method, and I would ask our residents or our med students, why do I think this is from maternal factors, right? And really the answer is there is entirely too much happening in this screening test. There's too many chromosomes that are abnormal. If we focus in on this one, it's chromosome 17, and it's not actually the whole chromosome that's gained. It's a small part of it that's amplified. And in that small part that's amplified, these red dots is ERBB2, that you might also know as HER2. And that is decidedly not a normal finding in a placenta ever. And so we asked for a second sample, and it was present again. And so at this point, the patient was given an indeterminate result due to maternal factors, but a conversation was had with the clinician that said, we're concerned, very concerned about malignancy. Which malignancy? Well, HER2 amplifications are found in breast cancer and lung cancer and gastroesophageal cancers and colon cancers, and I'm sure I can find other case reports of HER2 amplification in tumors. And it would take over 3 months for her to eventually get a diagnosis of metastatic breast cancer, 2 lymph nodes, and coming as a surprise to absolutely no one, it was HER2 amplified. And we could monitor her. So we have our prenatal, postpartum, and then after therapy, and the HER2 is gone after therapy. We were able to publish this case report, and I think what makes it more profound for me is the patient actually commented in her own words from her perspective about what had happened. And I'd like to highlight this sentence, particularly for the New York Times. Those results and the trust I had in my doctors saved my life. It just gives me chills thinking about, like, we were able to do this for someone. So to this list of biological variables that I have to think about when we're doing prenatal testing, right? I spend a lot of time being concerned about false negatives, if the fetal fraction is low or if the maternal weight is off and impeding our ability to read the assay. We have to think about false positives that include maternal malignancy. And that has very helpfully gotten us to the somatic portion of this talk. I think everyone here, particularly our anatomic pathologists who I get to see in the audience, have heard that they're going to be replaced by liquid biopsies. And as an anatomic pathologist, I can tell you that's not going to happen because there are a lot of things that we have to offer for margins and status. And there's so much going on when you're diagnosing someone with cancer. And so this is my highly suspicious Facebook avatar. And it really prompted a number of organizations to get together and put out this article that basically said, this is not yet ready for prime time. There are other tests to be done. We need to understand the sensitivity. We need to understand what this means for patient care. If any of you are in Michigan, former ASCO president Dr. Hayes has apparently run out of lunch partners. Maybe somebody meet with him. That's not to say it's all bad. There's actually a number of somatic cell-free DNA assays that are in use and approved by the FDA. The ones pictured here are all intended for patients who are known to have cancer. You've got COBUS for EGFR and lung cancers. This one from Resolution Biosciences was actually granted breakthrough status in the last couple of weeks for non-small cell lung cancers, particularly for looking for KRAS G12C mutations. There's TheraScreen for PIK3CA and breast cancer, and probably the ones people are most familiar with would be Guardant, that has 73 genes and select fusions, and then also Foundation. And then this has 324 some odd genes, fusions, and also looks at tumor mutational burden in the blood as well as microsatellite status. Again, all of these are for specific cancers, for patients who are known to have cancer, and are for guiding therapy decision for FDA-approved drugs. That's different from this other one I'm going to highlight here, Signatera. They were also granted breakthrough status. And Signatera is basically, there's a number of publications, colorectal cancer featured most prominently, but also bladder, breast, I believe lung. And then what they were doing was basically bespoke testing. So they were looking for 16 mutations that they identified in FFPE and then looking for it in blood to see if tumor was still there, so monitoring minimal residual disease, or to see if there had been a recurrence. And when you read these papers, it's phenomenal, like 85% sensitivity, and it does this wonderful thing in 9 months lead time. I was, optimistic. And then I read an article that came out from, I think, Center, I want to get this name right. I have to scroll down. City of Hope Comprehensive Cancer Care Center. And it turns out what Signatera was doing, the study for colorectal cancer was actually conducted in Denmark. And so when they were screening colorectal cancer patients, the imaging that they were doing was once a year. And NCCN guidelines are actually for you to do imaging every 3 to 6 months for the first several years, and then every year after that for several years. And so these lead times that they were offering, I think, a 9-month lead time, well, if you're not screening but every year, that's kind of a no-brainer that might happen. And so this study basically looked at what was first to detect basically did the imaging on NCCN guideline recommendations, and then looked at ctDNA imaging and then CEA measurements as well. And I've got a Venn diagram here basically showing that imaging was eventually able to identify all the alterations, whereas ctDNA remained negative in about 40% of cancer patients that had recurrence. It is worth noting, though, that ctDNA was first for 5-ish patients, and that it did offer lead times of 1 to 20 months. Some of the patients who had diffuse peritoneal disease were not picked up for quite a bit of time, so it may be that it's not all good, it's not all bad. There is a use for it, but it's not the only way that we should be monitoring patients. One of the other criticisms that cell-free DNA tests accrue is that there is poor congruence between different commercial platforms. And I apologize to our red-green colorblind members of the audience. This would have been a bit of a feat to fix. Look for the letters. And basically all of the green are the things that are concordant, and all of the things that are in red are not. Things that are in blue basically meant one or the other assay didn't test for this, so that could not be assessed. As you'll see, there's a lot of red, things that don't match. Notably, both of these assays are using ultra-sensitive NGS methods. So they're sequencing these things 8,000 times. And you'd think that that could improve sensitivity, but really it's also introducing that possibility of false positives. What's also concerning is that there is potential that these are detecting non-prostate cancer, right? So this is 40 patients with metastatic prostate cancer, if I didn't say that, but detecting non-prostate cancer alterations, particularly when you start looking at some of the genes that these alterations are concordant in, like ATM and P53. And it could be that, especially in the patients where there's low tumor burden, right? So if we're doing that by PSA, if the PSA is under 10 and you're seeing all these congruent mutations, like tumor burden is not high here, and so you'd be worried about something like CHIP. So what is CHIP? This is clonal hematopoiesis of indeterminate potential. And basically it's the accumulation of mutations with age. And so you're seeing those in genes like DNMT3A and P53, ATM, et cetera, right? Many others. And by age 70 to 79, it's about 10%. And once you get into the 90s, we're at 20%. And it really, though, depends on the depth of coverage. And there are some studies that suggest with orders of magnitude coverage, we can actually get everyone to be positive for a P53 mutation. One of the things, maybe you know why I highlighted prostate cancer. I have to thank Dr. Pritchard for his slides that he was kind enough to share. We have a lot of data here in this sphere, and really what makes it unique is that we're not just testing circulating tumor DNA. For everyone that there's matched FFPE, we're testing that as well, and we're doing a whole blood control by comparison. And so when you're looking at the alterations, here it's a little bit different. Green means that they agree between FFPE and the circulating tumor DNA. For patients that have high disease burden, we have excellent concordance. For patients with low disease burden, we're not finding these things in circulating tumor DNA because there's not enough of the analyte, presumably. And again, what I'm highlighting is by doing that whole blood comparison, we can actually attribute the mutations that we're finding in cell-free DNA to tumor or to something else. And so in this study done by one of our former fellows with Dr. Pritchard and Eric Connick, they basically found that 20% of patients had CHIP, and you can see this age curve recapitulated. And about half of those were actually in genes that made you eligible for PARP. So 7 patients got results that somebody might have said PARP, and actually one of the patients had, unbeknownst to the study, gone to commercial testing. They'd found a BRCA mutation and PARP was recommended. And so really accounting for these CHIP mutations is extremely important when selecting therapy. So I've been talking about blood a lot. It turns out we can look in other compartments as well for cell-free DNA. This was pre-access to BioRender. I've been using a lot of the BioRender images, but basically we can take from these fluids, we can centrifuge, take that supernatant, and then run our assays. And work that I did with the people pictured here, we actually had 29 samples, paired cytology samples, of FFPE and supernatant left over from making the cell block. And admittedly, 13 of these samples went to our former hotspot that's been sunset. 17 of them went to Oncoplex, but what I want to highlight is that there was 90% mutation concordance between FFPE and the supernatant from cytology, not only for mutations, but also for copy number variants and a fusion. One of our pancreatic cancers actually had an NTRK fusion that renders you eligible for NTRK inhibitors. 2 of the samples were actually positive on supernatant alone, and this suggests that when you have a cell block that has really low tumor content in it, or you don't have enough of a cell block after you're done with IHC, rather than sending the patient back for another procedure, if we save that supernatant, you might be able to test it to see if there's a mutation. We also have a lot of experience on the CSF end of things. I've gotten to work on a number of projects with fantastic collaborators, many who have been kind enough to share some of the slides that you're going to see next. In these assays, we've looked at FFPE and CSF from patients, and then they've either gone on to one of 2 platforms, both of which I've discussed, Oncoplex or our low-pass whole genome sequencing that's used for prenatal testing. The first was a feasibility study. There were about 15 patients, predominantly medulloblastoma, but we also had ATRTs and some low and high-grade gliomas, so pilocytic astrocytoma and a pleomorphic xanthoastrocytoma. And like I said, we put these on Oncoplex. We're looking at a graph here of what the yield of DNA was. And I'll tell you, 1 nanogram seemed to be that sweet spot. If we got over that, we could get tumor profiles from the cell-free DNA. And for all of those cases that were successful, about half failed, but for the half that succeeded, all of those alterations were actually concordant with FFPE, including a BRAF fusion. Fusions are notoriously difficult to pick up, which is why I'm highlighting our ability to detect these. In a different cohort of patients, predominantly focused on embryonal tumors, so these were medulloblastomas, ATRTs, embryonal tumors with multilayered rosettes, and then not elsewhere classified. These went through our low-pass whole genome sequencing. What's different about this is it requires less DNA. And so I think you can tell why maybe it was a bit more successful. Actually, all 30 samples, only 1 sample was insufficient, we're able to get data from. 23 of those samples were positive for copy alterations that were consistent with tumor. And I'll say one of these false, one of these negatives was actually an ATRT that didn't have copy alterations, so as far as I'm concerned, it doesn't count. And I want to show just a little bit of that data. We've got a Wnt-activated medulloblastoma here. These have beta-catenin mutations and also are accompanied by monosomy 6. I think it's pretty easy to pick out that chromosome 6 is hanging out here at the bottom. If we look at the Oncoplex data, this is a little harder to tell, but I think you can appreciate that chromosome 6 is beneath the little 0 line here. A slightly different case of group 3 medulloblastoma, a lot of copy number changes here, including this one, which is isodicentric 17, so you have loss of the P arm and gain of the Q arm. That one I think is a little bit easier to pick up on Oncoplex, again, concordant. So if we look at the time points where these different samples were taken from, I want to highlight the ones here at the staging of disease by lumbar puncture. Of the 9 samples that had cytology on LP, 2 of them were positive by cytology. 7 of them were positive by molecular. One of those that wasn't identified by molecular was the ATRT that didn't have copy changes. And so now it really becomes, well, what do we do for these patients when we identify that tumor is still present in circulating tumor DNA or cell-free DNA in the CSF versus ones that were found in cytology? And it gives us some hypotheses to evaluate. And I want to do so by telling you about a different case that wasn't actually included in this study because the patient was seated at an outside hospital. 5-year-old had a medulloblastoma, was sent to Children's for radiation. 9 months after surgery, there were indeterminate changes on the MRI. Basically, they couldn't tell whether this was progression of the disease or pseudoprogression from radiation. Tumor board met and decided that they were going to do short interval MRI, but also suggested, knowing some of our past results, taking CSF. And we see a number of copy alterations here, including MYC amplification, which is a poor prognostic marker in the context of an ISO 17. And so this was a group 3 medulloblastoma recurrence in this patient, and we were able to identify it earlier and MRI later confirmed. And so they could start making treatment decisions. So I think I've demonstrated the benefits of liquid biopsy, especially when there's not FFPE material available. It can be less invasive. It's excellent for serial monitoring, especially if you're looking for resistance mechanisms. And then it can serve as a molecular proxy of overall disease. That means instead of getting that little piece of tissue from that one metastasis when there's metastases all over the body, I can actually see what's happening in all the compartments at once. But I think I've also highlighted that there are some limitations, such as benign clonal expansions, like CHIP, which doesn't just affect heme genes, but can also cause mutations in KRAS, BRAF, NRAS, PIK3CA, things that we're using to make treatment decisions. There's also clonal expansions in other compartments. So if you do a bronchoalveolar lavage, you might find P53 mutations, but it doesn't mean that this is going to become a cancer. Identifying a mutation also lacks specificity. I can see, I told you at the beginning of this, BRAF V600E and everything from benign nevi, Langerhans cell histiocytosis, brain tumors, colorectal cancer, lung cancer, thyroid cancer, etc., right? So finding this mutation doesn't tell me where the tumor is. And it doesn't even help me select therapy because some of these indications don't respond to the vemurafenib drug for BRAF. So how are we going to accomplish moonshot? I don't know if you guys have been following all the press, but it's this idea that we can do blood tests for multi-cancer early detection, or MCED. That one takes a little bit. I keep hearing NSAID. Don't think that is necessarily a good idea. Well, there's a number of groups working on it. Obviously, you can't do it just based on mutations, right? And so what we're looking at now are things like epigenetics, fragmentomics, and topology of the DNA. You have places like Johns Hopkins that spun off to Thrive that was bought by Exact, where they were doing mutation testing plus protein screening, so looking for CEA and CA19 and other cancer protein markers. You have groups who are just looking at fragmentation patterns across the whole genome to decide if they can find the tumor of origin tissue. There's also this one people might be more familiar with, GRAIL or Gallery testing, where you're looking at methylation patterns. There's groups that are trying to do various combinations of this, right? And this is not an exhaustive list. I have a review that could give you one. There's probably 30 or 40 different companies that are doing various parts of this. And the idea is to try to increase that specificity and to really understand where the mutations are coming from. So where does that leave us? With a coming onslaught of information, there are thousands of trials that are using cell-free and circulating tumor DNA underway right now. And some of them, when I was doing the reading, are actually really scary, where they're taking patients and saying, like, if we don't detect circulating tumor DNA, we're going to de-escalate therapy. Presumably, hopefully, they're also doing imaging or some other things in there as well. But one of the ones I really want to highlight, just to bring us full circle, is a trial called Identify. And I really love the people that are coming up with these names. But basically, this is for women, like our patient, who get an indeterminate result, presumably for maternal alterations, maternal malignancy is suspected. And they can be screened and then actually undergo all the imaging and testing that they need to do when they went in thinking they were going to discover the sex of their baby and are instead told they might have cancer. Early data suggests that maybe about half of them are found to have neoplasms. I have helpfully summarized all of what we've talked today. Again, I did mention that there is a little bit of variability as to who thinks what's going where, and I think in the right hands this can actually do a lot of good, but there is a lot of data that's still needed to understand the utility of these tests. With that, thank you to all of my fabulous colleagues, our lab staff, everyone that's supported this research with grants and time and reading of papers. And I've been to all the coasts, and the West Coast is the best coast. And that leaves us with a very long bibliography I will leave up here for a little bit, and I'll take any questions you might have, and then we'll put up the QR code shortly.
Fantastic. Really great talk. Thank you so much. Very clear and powerful. As somebody who's an anatomic pathologist and way behind, I admit that I had amniocentesis back before any of these tests were even available. Thinking about breast cancer and that they still require tissue samples for known metastatic disease. So right now, standard of care here is, you know the woman has breast cancer, she comes with a MET, and the standard of care is still biopsy that MET, and then send it to us to say, yes, it's cancer, and then to you.
To do molecular.
To do molecular. How far are we from stopping that practice?
So the question is, metastases basically require a pathologic diagnosis for appropriate therapy. I think there are a number of factors to consider there. I think there is utility in maybe not having to require that, but there's enough caveats, and I've seen enough cases now where someone tells me this is a metastatic whatever, and it winds up being a secondary cancer, to where I do feel like tissue testing, at least of some of the metastases, not all, but just making sure that this is not, another cancer, and then looking at some of the markers that they want to look at, assessing the ER status requires tissue. And so really it's being thoughtful about, if you're trying to get a PIK3CA mutation for a woman who has breast cancer, I don't know that we need to keep doing metastases, like the biopsy of metastasis. If that's specifically what you're looking for, then doing a TheraScreen every 3 months or 6 months or something to be able to add that on, that might be appropriate, but as far as completely replacing tissue, I'm still a bit reluctant, and I don't know that we'll get there anytime soon. So.
Yes, so the questions online. So Mark Weiner says, how much will CHIP interfere with screening diagnosis of malignancies? And is there a routine algorithm to normalize for CHIP, determine if the finding has specificity for malignancy? And do we have a standard for that?
So this, I think, does that mean that I should repeat the question for this one?
CHIP assay. Do we have a standard CHIP assay for that?
Well, really, it's what we do here at UW, right? You use that whole blood comparison to look for CHIP. And so there is a really great review that just came out in the last month that basically looked at what they were trying to do to decide what was CHIP and what was tissue of origin, and making a comparison between fragmentation and between methylome and between mutations. And so I think you can do a little bit of either use a whole blood comparison, which is probably the easiest answer, but you can also look at the fragmentation patterns, because the fragmentation patterns of mutations, like the DNA that they reside on, changes the fragment size. And so they're actually doing some of that in pregnancy screening as well, trying to decide whether or not those microduplications and deletions can be attributed to like the fetal compartment versus the maternal based on those size differences. But there's not a everybody's doing this one way kind of gold standard, other than I like to think what we're doing would be the best approach.
Another question online from Erica Dillon. Have states that have banned abortions also banned the use of prenatal cfDNA testing?
They have not. To the best of my knowledge, they have not, but it has presented a problem, and I actually have friends that are practicing OBGYNs in Texas, and one of them has left her field because of feeling unable to provide care for patients. It's not to say that the results that you get mean that you have to make a decision about pregnancy termination, but it does allow for preparation, pictures of the baby, if they pass right quickly after they're born, and allowing the family to kind of come to terms with that earlier in the process, rather than getting kind of you've just given birth and now we're telling you your child has a lethal anomaly. So no, I think there's still a space even in states where they have banned abortion.
Can I follow up on Susie's question? So I couldn't tell if you're doing targeted oncoplex in cell-free DNA ever, and would that help improve specificity and sensitivity to avoid doing biopsies of later metastases?
Say that again.
So do you do targeted capture like oncoplex in cell-free DNA?
Yes, you can.
Does that help get at Susie's question of not doing biopsies anymore?
It does help a little bit at getting at that question, in particular for the child that had the CSF recurrence. I think we actually did oncoplex on that as well and had data that demonstrated the same thing. So you can get mutation testing on that as well. Just this week I had a repeat lumbar puncture for a patient who has FGFR1 mutations. Bonnie is probably watching, and I'll tell her I couldn't find any mutations on the repeat biopsy, but we are using that in lieu of doing additional, right? You don't want to go in and do multiple brain biopsies on a patient.
Another question online along those lines. How long does cell-free DNA persist in CSF after tumor resection, if the tumor resection is complete?
Yeah, it's on the order of, it's probably more, it's longer than, say, you would have in blood, but it's on the order of hours to days, probably max. It doesn't persist long.
You were talking about how there are limitations in the way, our fragmentation size of cell-free DNA could be limited by our isolation techniques. Can you say more about that?
We've all, at least when I started, walked around thinking everybody's walking around with like 166 base pairs, and there's a really excellent article that Dennis Lowe wrote that says that there are actually also multi-kb fragments that are in the blood, and because of the methods that we're using to isolate the cell-free DNA, we're specifically looking for things that are smaller, but that it was something like upwards of 10% of the DNA that was present in blood was actually multi-kb.
So how are we losing that? Do you know?
I'm looking in my head for,
Okay.
and/or I have an excellent review article for you. I'd have to look specifically at what it is. It could be the way that we're pelleting. I don't know that I recall that he specifically talked about how that was happening. It's a lot. I'm like carrying around all the sensitivities and specificities in my brain, and I will now dump them.
Great. Let's thank Dr. Paulson for the time.